beam. We are discharging home now. I'm going to ask that group 20 please share with me 2 things that you guys identified as being part of transitions of care at this point.
About HIP. I thought they did it last. Maybe that's what it was. Huh?
I was gonna say Ainsley did that new basically the marijuana drug for kids with epilepsy.
Real.
Ainsley did that. And Circus is okay, they're not the same class.
We said to educate her on the new diabetes regimen. We also said that we gave education points for Lantus, but we also mentioned that she could just be discharged on metformin 500 milligrams BID instead of going straight to insulin. And then we also mentioned that we should counsel her on remembering to take all of these medications since she was only taking omeprazole in the beginning, like using pill packs or putting them in a spot where she'll remember to take them.
Awesome. Group 2, what do you have in addition, or 2 different things that you identified for transitions?
When is it?
Right.
I walked in 2 days ago. I was like, so I don't know who's hot yet. She should do this. And then it might be on the 19th. It's just like, oh, well, we'll get it done. It's fine.
Dang.
Yeah,
I really like her.
When is it going to be though? Since we don't have like the
Okay, so we agree with what they said, and we also included some. Well, first, want to ensure that the most appropriate and correct medication are continued on discharge. So, for example, you should pretty much continue all of her medications except for maybe the Lantus. That could get changed to something else to manage your diabetes. And we also want to counsel her on lifestyle education, especially about smoking cessation and to reduce alcohol consumption, and also to try and have a better diet and to exercise more.
Awesome job, you guys. I love it when you put your heads together. Okay, so the groups that shared what they found did a really good job in combination to identify a lot of the really important things at this transition, okay? So most of all, what I wanted to kind of drill into you guys here is that this is going to take a lot of collaboration. Not only with the team, it's going to take collaboration with the patient's family, caregivers, it's going to take collaboration with the patient. If the patient is not on board at this point, you're going to have a real problem because all of the education that you're going to provide, everything that you're hoping to achieve is not going to work if the patient's not co-signing what you're giving them, okay? So, a big part of this is going to be education. Providing that diabetes pathophysiology education at this point, if you haven't already, because it could have been done on a different hospital day, but refreshing them here is never, it's not going to hurt anything. So in terms of their self-care as well as their new medications. Both groups made a really good point. We started insulin in-house, but that doesn't mean that it needs to be continued. At the very beginning of our lecture, we talked about the fact that we want to kind of check out insurances, see what this patient can afford. If she doesn't have any insurance, maybe she can't afford Lantus. And so maybe starting one of those medications that you can get for free at a pharmacy, something like a metformin is going to be what we need to head towards. And so both groups kind of hit the nail on the head there in saying we don't have to continue Lantus outpatient. We can go to oral therapies here. Now, depending on your interpretation of the new 2019 ADA guidelines, when you guys take a look, there is a stipulation there where if you wanted to start injectable therapy, it could start if your patient is at an A1C of greater than 10% and or 2% over their target. So this patient's A1C is at 9%. That is 2% over the target of 7%. So it could be justified, depending on who you speak to, that you start insulin or a combination injectable therapy of a GLP-1 agonist as well as a basal insulin in this patient, okay? So just keep it in mind, there's a lot of ways you can go to treat this patient's diabetes. They're all going to be very dependent on the different variables in terms of the patient's insurance, what she's willing to do for her diabetes, and what she feels like she can take care of at home, as well as incorporating the fact that she has a slew of other medications to start because of this heart attack. Once you have a heart attack, there's a lot of meds that you get put on, and so being mindful of that, and that will lead me right into my conversation about adherence. So the first group that shared their information, spot on there. Remember to take all of your meds. Stressing adherence for this patient is going to be very, very important because those meds are designed to help decrease her morbidity and mortality associated with this heart attack and try to prevent it from happening again. And those pearls that the group gave in terms of maybe you should get a pill box. Maybe you put your medications where you can remember. I was watching TV the other day and Amazon has this new thing where they bag up your pills for you in like little packets for the specific days. That's awesome. I didn't even know it existed. I should watch more TV apparently. And so giving them these different things that they can use to help make sure that they remember their medications. I know one that I use a lot for my patients, set an alarm on your phone. You'd be surprised how many older patients actually have smartphones. They don't know how to use them, but you can teach them to use their alarm if you have to. And so giving those recommendations there. So adherence is a really good point here. One of the things that the groups mentioned earlier that I did not give enough kudos to was this idea of continuing an H2RA inpatient because the patient was taking a PPI outpatient in terms of the fact that they were on dual antiplatelet therapy. So I remember it being mentioned. My apologies for not giving you your kudos then. That's definitely something that could have happened in-house. As you see, we didn't have it on the inpatient medications, but definitely something that could have been added. And you can see here, at this point, the recommendation was made. No longer take that omeprazole because of the therapy that you're on, but you can consider starting an H2RA if you want to continue that outpatient, okay? The last thing here that wasn't mentioned, and it's likely because it's just kind of, we expect patients to do these things, but it's the encouragement for your patient to go to that hospital follow-up. You guys may have heard in the past these terms about insurances and quality measures and 30-day readmission rates. And so heart attacks is one of the things that gets dinged for patients if they come back. And so making sure that your patient is heading out and staying out and doing their follow-up, whether it's a 7-day or a 14-day follow-up with their outpatient provider, is going to be important because it can help keep them healthy versus them not following up at all. You guys talked a little bit about the education in terms of lifestyle. Very great. I'm so glad to hear that we were talking about smoking cessation and decreasing alcohol. Both things can increase your cardiovascular risk. So having that conversation with her at this point, if it hadn't already happened earlier, is going to be important. So very, very good catch there, as well as the exercise and the diet. All things that are going to be important for her to be mindful of. So just to clarify with you guys, when we're giving that medication education, you want to focus on everything here. So really break it down for the patient. It may feel like you're breaking it down to a level that's lower than you feel like you need to be, but sometimes that's where we need to be for our patients. So really honing in on that indication, what the dose is, when they need to seek any type of medical attention. So let's say we sent her home on insulin, really making sure that she understood what hypoglycemia felt like and whether or not she was having an episode and how to treat that is going to be an important part of your education, okay? I heard from other groups talking about adverse effects is going to be important too. And then always proper storage is important. So we were saying, put them in a spot where you remember. But if your patient is like, oh, I'll remember to take these after I get out of the shower, that's not the best place for them to keep their pills, and we all know that. And so making sure you still give that education about proper storage, it's going to be important for your patients when they're starting on this many different medications, okay? At this point, depending on if she's only taking oral medications for her diabetes, some people won't start her on a glucometer. There's a big debate about it, whether or not patients who are only taking orals need to have and check their blood sugars. If she is started on a glucometer, education about that is going to be really helpful for her as well. And so that may be something that you do in-house, show her how to use it, have her utilize the teach-back method. You utilize the teach-back method so that she can show you that she knows how to use it. And then occasionally, there are usually protocols in place for this in hospitals, but making sure that your patient is well up to date on the vaccinations as well. In this patient, group 17, because of her new diagnosis, what vaccination am I thinking of that she may need if she has not already received?
Prevnar?
Guess the other one.
Pneumovax?
So close. Very nice job. So, Pneumovax is what we're going to want to make sure that she has. Everybody should always get their flu shot. Yay. But Pneumovax is what we're looking at for this patient in diabetes. Now, most oftentimes, when in hospital, there are protocols in place where this gets taken care of by a nurse and you don't even know what happens, but it's definitely on the MAR. But if for some reason it wasn't taken care of in-house, that's what you want to educate here, something that you can make sure that she's getting done in her transitions as well, okay? And the last thing that I want to mention here is this concept of access to care. We've mentioned insurances a couple of times. Not everyone has the best insurance. Not everyone has insurance at all. And so sometimes cost can be a really big deal here. So even though the guidelines might recommend a certain therapy, when we're looking at the middle of our JCPP patient care process and that patient-centered care, we really need to take costs into consideration. So just because the guidelines say that it's the best or that it's first line or that's what we need to use, it doesn't always mean that that's what we're going to go with. Constantly in your role as a pharmacist, you are going to be weighing those cost benefits and risks with those guideline recommendations and determining whether or not we really can go with the guideline-directed therapy, or do we need to give something else that the patient can afford that may not have the most stellar evidence associated with it, but can still reduce their morbidity and mortality in the future, okay? So keeping that in mind moving forward, it's not always about the best blockbuster drug, but making sure that our patients are treated appropriately, not only for their clinical diagnosis, but also for their own personal situations. Very nice job, you guys. What questions do you have for me, or what maybe other things of transition that I haven't already mentioned did any of the groups think through?
Our group also added a PRN order for nitroglycerin for the STEMI. Would you do that as well?
Thank you for that. Yes, giving them some nitroglycerin, definitely something that would be an option here. And so, wasn't included, I didn't mention it, but it's definitely something you can think through. So getting them some nitro, make sure if they have any chest pain in the future, they can combat that. And along with getting them that nitro, making sure that they have the education of how to take it. So knowing that after that third one, it's time to call 911, is going to be important for them. Anything else, you guys? Storage for that nitro, also important. I've had a couple of patients who put that in their pill box, so on and so forth. You got to make sure that they know to keep it in that bottle and keep it away from moisture. So it may seem like it's something that they should know, but not everyone always does. All right. Our very last transition of the day, you guys are doing stellar, okay? I want you to take some time. This one isn't as heavy in terms of the meat and potatoes. That discharge is a big one, and it's one of the biggest places we can have an impact. But we're now at that 14-day follow-up. Dr. Norton earlier was talking a little bit about this provider status lecture you guys are going to get. And so this is the ideal situation child of that in terms of clinical pharmacist management. They came to see the pharmacist for their follow-up instead of their primary care provider, okay? And so at this point, they're here for this appointment, and this is specifically for their diabetes mellitus, okay? And we're taking a look at the medications, and this list is coming from your patient. So yes, your patient was discharged with specific medications and a specific list, but when they sat in front of you today, it is these meds that they told you, yes, I'm taking these at home, they are definitely getting into my body, okay? What are the types of things that we're doing at this appointment in terms of this transition from the hospital to this appointment and making sure that they get home, they're safe, they're efficacious, and we can make sure that they have what they need to continue to keep themselves healthy as it relates to their diabetes diagnosis. Take about 8 to 10 minutes, work through that with your groups. You guys have been doing a really great job thus far, and we'll come back together and we'll finish this up for the day.
Non-Athens.
Non-Athens.
That's it, right there.
It's just
Why can't
satellite or
we leave it
distant
at
works
distant?
fine.
Like, it's just distant campus, right? I've
Yeah,
always
that's what I call
called
it,
the
for
distant.
satellite.
Wow, that's really dumb, but I'm glad our priorities are maybe.
This is important.
I respect it.
What was choice.
Yeah. Choose non-Athens campuses?
No. Athens is not the only important
I know, right?
Non-Athens makes everything else seem inferior.
Yeah.
When we all know in reality that Athens is inferior.
Yeah.
Non-Athens. These are the other campuses.
Goes Augusta, Savannah, Athens, Albany. Goes Augusta, Savannah, Athens, Albany.
Yeah, Albany's like dirt.
Why are they choosing an Alfred?
Yeah, why are you doing that? You want, maybe she can afford that.
What's that across the street from an Alfred?
I know. Maybe she's like, no, this one's working for me. I want to change something.
Maybe she has bomb insurance.
Yeah.
I mean, she's getting Exenatide. So, what is that? Iberian? Is Nigerian one of the things that has like good data for heart failure? And they're like one of them. No, that was Victoria. When we were learning about heart failure or diabetes. No. But Nigerian is good for like prolonging the time to insulin, right? Victoria for sure is an empagliflozin. Farxiga, I believe, is like.
The good heart ones?
Bad heart.
Are they bad for you?
Glutazen's are bad.
The gluten ones are good?
The only good ones were the Flozins, Victoza, empagliflozin.
No heart. Sitagliptin is preferred, so they have to be on two.
Because the gluten's very rare.
The saxagliptin ones has an increased heart rate.
When did you get this?
This is from my diabetes elective.
Okay, I was like, this is not recent.
This is.
You didn't have this at the pad when we went over this 2 years ago. So why
No, I use this as like all these charts right here. It's literally all taking the diabetes section. I have like well, I'm probably not gonna have any on it because it's
No, it was like 11 a.m.
Sorry to take over your.
It was like in the morning of the day before it was
I usually have a studies one. I can't pay attention to the studies. Oh, maybe.
Did you think about it? I was gonna say, it would be different.
Maybe it was like, you didn't see it?
There's a substation. Put it all on me and so when she goes,
It should be. There it is, there.
yeah, I really am.
Yeah, I just have
Oh.
the Victoza for sure.
I think she does.
And yeah, I think we got those too. But the
Not quite as like structured.
Exenatide, that one.
Those are the ones that you lose weight, like 5 or 10 pounds, right?
Yeah.
Yep, and weight loss.
Oh yeah, it's in the medullary cell carcinoma. He's in the So she's on a follow-up for diabetes stuff. This is her new labs?
My dad's under and now my mom's
New what?
Are these her new labs or the ones that she got when she was like before?
I have no idea. Because they look the same.
They are different.
Yeah. Why?
No, they're different patients. I'm asking for this patient.
This is the same patient.
Is it?
Yeah. J.O.
We took her off the omeprazole. Why'd she start taking it again?
Because she's at home now.
It's OTC.
We told her not to take
Well,
it.
when do they
Why is she non-compliant? She's gonna have a clot because her clopidogrel isn't working.
My sister gave me a Kinderstop necklace.
And she's gonna get an ulcer when she stops taking it because she's not taking an H2RA.
You wanna know what I got her?
She's trash.
It's like $150. I got a face mask. My sister asked me if she could use
Your ears look dry.
Wait, here?
Yeah.
It's because there's like some tumor growing on my ear or something like that. This one's fine. But feel this. Like, just press.
Feels like you got your ear pierced.
I know, like, there's one little one in the middle, but then there's like this big ass thing on the edge. Like, I have ear cancer or something. But it's fine.
You see the little girl that opened the Taco Bell gift card? And that's
I know what
also
long it is. You never seen Lonzo Rose?
I've never paid too much attention to it.
Oh yeah.
Be more observant.
It's like right here. I have endometriosis.
Aubrey has an acid. Girl,
It's been a very long time.
Very long is different. Very long.
it's on his
A year and some change.
Okay.
No, it's not. It's like awesome in theory.
No, yeah, it's kind of like that. Yeah, it's like that. Cauliflower. Is that just if you get hit? Is that just if you get hit a bunch? Maybe he's a boxer. Smart. Do you have a pencil in your ear?
Yes, so smart.
Have you ever seen those videos where they take the earwax or they like impacted earwax that people use? You should watch it. It is so sad. Oh, ear.
Did you watch the one with the cockroach?
Huh?
Did you watch the one with the cockroach inside?
No, oh my god, you guys. I woke up with a cockroach in my ear one time.
No, you didn't.
Yes, I left my window.
So yeah, so someone tagged so one of my friends was like shared this video. It's like a ear like what's it called? Like compounded earwax, right? So I thought I was like, oh okay. They get to the end and there's like a full ass dead bug inside, and that's what caused it.
This one was live. You guys. I left my window open when I slept one time, and a little roach reached itself on my ear. I could hear it like coming around and like scratching my
Aaron,
ear around.
I would have cut my ear off.
Yeah, I was about to kill myself.
One of my friends
My mom
said
didn't
that
believe me.
they
She
woke
thought I was
up with
having
a
like a
cockroach
bad
in their bed. Like, I was like, okay, that's gross. This just takes it to a full other level. Inside your ear.
I kept telling her, I was like, Mom, there's something in my ear. And like, it would like
How did you
jiggle.
get it out?
I hit my head like that.
You have what in your head?
My mom was just like, Aaron, you're having a bad dream again. You should have said, oh, no, no.
How old are you?
Like, 18.
Oh. Aaron, you're just having a bad dream. Go back to sleep. Quit saying stupid things.
So yeah, I was like, I did that really hard and it fell out. I was like, what did I tell you, Mom?
Oh.
No, I'm not. You can ask my mom. She's a little
I really don't know.
The little ones are the bad ones, though.
yeah, well, so they get lodged in you.
How did you even let it get on your face?
He was sleeping.
My window open, so I got in.
And it
Woke
just
up,
let it
something
fall.
like scratching inside my ear.
Oh my god.
Take her ear and scratch it, that's what it sounded like.
So what did you do?
I would probably kill myself.
Hmm?
I would probably kill myself.
It's just at that moment.
Other side?
Yeah, I would. He ate his way through your brain.
Okay, still, it's just about the topics. No, I'm talking about it.
Okay.
The video is really short. You want to watch it?
No,
Audio.
absolutely
I do
not.
not.
Yeah, it was hysterical. There was something going on in that year that I didn't know.
All right, you guys, it's about 10 minutes there. I'm going to start with group 7. If you could please share with me 2 of the things that you identified could be optimized, maximized, anything in regards to her patient transitions of care.
Probably something going on too.
Oh my god.
Take your chance anytime. I know.
Like, why would you not at least boil that water before you put it up your nose? Like, wouldn't even have any sympathy for you at that point. It's funny. Not that I but
Maybe Bond is one of those.
Smoking and alcohol.
I love Nutty Box.
I think you said smoking and alcohol cessation.
Y'all know the ones earwax?
Yeah.
I don't
That's
like
right.
earwax.
Okay, anything else?
You can't watch that.
It starts off at earwax. It's just earwax at first.
Oh, you're gonna make me watch it. Cool.
All right. Group 16, what are 2 things maybe that are different from smoking and alcohol cessation that you identified should be done here?
I'm dead or alive? It's dead. Oh my gosh. What group did you
Imagine being a doctor like that.
I heard the word omeprazole. I'm assuming you meant, what do you want to do with omeprazole?
I want to be an EMT.
Not too late to switch professions.
Sorry, our mic wasn't working. We said we changed the result in H2RA, and we also asked about adherent storage and barriers to care. So like when you're doing this dose, are you having any issues affording your medication, and how do you remember to take your medication?
Very good. So very nice job, you guys. What else, besides what Group 7 and Group 16 share with us, are there any other things that any other groups identified that they want to share with the group now?
Glucose readings, if she was taking any, and possibly increase her metformin to 1,000 milligrams BID. Also, she could possibly switch to metoprolol succinate to reduce her pill burden because it's 1 time a day instead of BID.
Very good. I had in Albany, you guys were saying, was it the metformin? Okay, so glucose readings and metformin here in Albany. Anything else?
Ask her who put her on the exenatide and when she started that.
So, very good job. Anything else, you guys? Next. Go ahead. You weren't getting ready to say anything? Okay. So, you guys have all identified really great things here, all right? The one thing that I do want to highlight here, the question about the exenatide that just came up. Oftentimes, when you see a patient come to you telling you that they're taking these medications, these could be discharge prescriptions that the team may have written, and so it could have been that upon discharge, the team decided we were going to start her on metformin and exenatide and give her prescriptions and send her out the door to go get those filled. And so it's oftentimes that they get these discharge prescriptions in the hospital, and so that's likely where she got the prescription from. But you're right, it could have been anyone. So maybe she followed up with an endocrinology provider, depending on what referrals were made. But in this case, that's the way we're going to look at it. The discharge team decided this is what we're going to start for her treatment. Okay? All right. Highlighting some of the things that you guys said. Smoking and alcohol cessation. Definitely important here. I don't have it listed on my side, but that doesn't mean that it is not important. So she currently is still smoking and drinking. We're trying to decrease her cardiovascular risk, so encouraging her to stop both of those with the skills that you guys have likely learned previously are going to be important. Okay? I heard checking on her blood glucose levels and possibly increasing metformin. I had that thought too. And so whether or not we have to discuss with a provider is really, that's determined by the type of practice that you're in. If you have a collaborative drug practice agreement with that clinic, then you don't typically have to say anything to the provider. But if you're just working off of recommendations, maybe you have to have that discussion with her provider before you can increase that metformin to that max dose. But definitely doable if tolerable. The comment was made about increasing adherence and decreasing pill burden to switch the metoprolol to metoprolol succinate. That's a reasonable decision. The same thing can be done here for the metformin. If the patient is having any of those GI upsets or GI issues, or if they just need something that they can take less pills of, possibly giving them the ER formulation could be beneficial, so that they can have that decreased GI side effects as well as decreased pill burden. I heard a comment about adherence issues and having those frank discussions. Are you having any issues? What does it look like cost-wise for you? How can we best help you stay adherent to your therapies? And I think that's a really important conversation to have with the patient at this point, because we're still early enough in the game where we can really make some changes and still have an impact on the efficacy and meeting our goals, okay? Noted here, her blood pressure on your documents, 121/80 with a heart rate of 68. Some may say that looks like a really great blood pressure, and some may say that looks like you're heading into hypotension. And so just making sure we keep an eye on those things, having those discussions with her, describing in layman's terms what hypotension feels like, and seeing if she's having any of those symptoms is going to be important here as well. And it may even prompt a change in some of the medications that can affect her blood pressure, whether that be altering the enalapril or possibly altering the dose of the metoprolol. So thinking through those things. We haven't quite reached that point yet, but if she has this blood pressure with symptoms, that would more so prompt you to make a change here versus just the blood pressure itself, okay? Again, looking at this inner circle of the patient care process, we're communicating with the patient about all the changes that we want to make. The only other one that I didn't just mention was the omeprazole, which was a good catch as well from that group in terms of changing to an H2RA. So you saw that the patient reported, I'm still taking my OTC omeprazole daily. Apparently our discharge counseling was not effective enough. And so making that intervention at this point, getting them off of that omeprazole and recommending an H2RA is going to be something we can do here as well. Collaborating, whether it be with the provider for that metformin, as always, we're collaborating with the patient to make sure that they're getting the best care possible, as well as we may even collaborate with, let's say, a pharmacy at this point. And so if the patient did say, well, I am having some issues with adherence, or I am having issues with being able to afford my medications, this is where you can come in and say, okay, let me talk to your local pharmacist, your community pharmacy, to see if there's any possible therapeutic interchanges that I can make it more affordable for you. Or let me check to see if there's any patient assistant programs that are available, or what we can do about your insurance. Maybe there's something else in the marketplace if they're on, let's say, any of the Affordable Care Act types of insurances that we can switch you to that might make it a little bit more affordable to you. So all different avenues you can go through to help the patient in collaborating with the patient and other providers to help get them the best care as possible. And ultimately, again, especially if you're having this visit and you're documenting and making changes, document those appropriately in the EHR so that everyone involved knows what it is you're doing and what changes you've made. And this is for whether it be billing, when and if provider status is in place. There are some billing things going on now that we can do incident to providers, and for just documentation purposes. The one thing that I did not hear from the group, though I did hear education, it was the teach-back method. So at this point, your patient has been taking these medications for however long. Maybe she has a glucometer, or maybe she doesn't. She likely has a blood pressure cuff by this time, having had a heart attack. And so making sure that your patient is using these things appropriately and identifying that by utilizing the teach-back method is going to be crucial here. So not only just giving them the information, but making sure that you know that they understand what it is that you're saying by having them show you what it is you just told them, okay? So using that method here is going to be crucial when it comes to patient education. One of the things that I always want you guys to keep in mind is health literacy. So when they get to your appointment, hey, how you doing? Heard you had a STEMI last week. It's not going to work. Typically, they don't know what a STEMI is. They may have heard it in the hospital, but you want to make sure you're using layman's terms with patients. So keeping health literacy in mind is always going to be important, not only when you're speaking, but for any paper documentation that you give patients as well. Say you give them a handout of their blood sugar goals or whatever it may have you, making sure that it's in a way that they can read. One of the things that works out really well, one of the things that has been popping up more and more across the U.S. are what's called patient-centered medical homes. And I want to give a plug in here for that because patient-centered medical homes make it really, really easy to be really great at transitions of care. In those places, you have your primary care provider, you have your specialist, you have your pharmacist, you have your dietitian, you have your social worker, you have your x-ray technicians, your lab, you have everything that the patient needs to make sure that they're taking the best care of themselves. And they just go to this one building or this one campus per se, and they don't have to go really far or go to a bunch of different appointments to get the care that they need. And so if you think of kind of the gold star of transitions of care and making sure that the patient gets what they need, it would be something like a patient-centered medical home. And if you ever have the opportunity to practice in one, you'll definitely get to see what it is I'm talking about there, okay? So that's my plug there for somewhere where transitions of care is really done very, very well. So you guys did solid work today. This format is very similar to what we're going to do next week, okay? We're going to work on a heart failure case next week, and it's very similar to what we're going to be looking at. You're going to be working in your groups, taking about 8 to 10 minutes for the different transitions for that patient. So it should look very familiar when we talk about that patient. If you haven't already, it will be helpful for you to watch the pre-lectures in terms of working through the different types of transition of care things to think through. But my hope is that by the time we got through this lecture, you were able to realize that you really do need to identify the different stakeholders when you're talking about the patient at different levels of their care. And so whether it be patients and their caregivers, or it be your healthcare team and the nurses, or your other pharmacists, knowing who it is that you need to wrap into the conversation and communicate with and collaborate with is going to be really important to completing that patient care process. A thorough med rec at every avenue is going to be crucial. And so always looking at your medications and making sure that you're optimizing, as well as making sure that they are efficacious, is going to be very important, no matter if the patient's just coming into the ED or getting discharged. And you guys did a stellar job with that today, okay? And my last thing that I want to tell you is that discharge counseling, as well as continued encouragement for your patients to follow up, is always going to be important when we talk about transitions of care. So in keeping those things in mind, I want to ask if there was anything else with this patient visit that any groups wanted to share with the class. Yes?
As far as like the ASCVD risk, do you think it would help her start to at least consider quitting if we told her likelihood of having another heart attack if she were to continue smoking?
So I have in the past shared a patient's ASCVD risk score with them. I think that thought process works a little bit better for this patient than it may work across the board, and I'm going to explain to you why. When the ASCVD risk score calculator was first developed, it was developed for patients who had never been on a statin before. So our patient in this case is the quintessential patient to use the ASCVD risk score calculator for, to get that risk and see whether or not they have a risk of having a heart attack or a stroke in the next 10 years. That's not always the case. So a lot of the patients that we're going to be trying to encourage to quit smoking and quit drinking, so on and so forth, are going to be patients who have been on these medications for a long, long time. And when you're calculating, though a lot of people in practice calculate ASCVD risk scores for those patients, the score isn't as accurate when it's calculated in a patient who's already been on a statin. And so to use that score to encourage them to quit isn't as accurate as using that score to encourage someone who is actually drug naive. So I think it can be utilized. The problem is that once you get over 7.5%, you're like, ooh, you're at a really high risk of having a heart attack or a stroke. But if you're anyone, out of 100%, 7.5 doesn't sound that bad, right? And so if you tell them 7.5% and you tell them that that puts you at a really high risk, they may not believe you because 7.5 is on this part of 100. So you can use the number, and for some patients who have a little bit more health literacy than others, it may be beneficial. But sometimes it may not have the exact punch that you're looking for to help them realize that stopping some of the things that they do in their social history may be beneficial. What other questions can I answer for you?
Is there anything we need to know about the quiz?
Not that I can think of. So if you paid attention today, as well as watched your pre-lectures, you should be able to perform on the quiz just fine. If that is not the case, I'd love to hear from you by email, and you can let me know if you felt differently. The quiz will be open until prior to class next week. So just make sure you take it prior to class next week, because it will close as of the start of class next week. But it'll open at 3:30. You'll be able to take that quiz right up until the beginning of class next week. Did I sufficiently answer your question?
Yes, thank you.
You're welcome. What other questions can I answer for you guys?